So let's talk about HIV infection and AIDS. It comes in different stages. Stage 1 is the first stage. That's where the acute response. So patients just finding out they have it. Now, chronic is the second one. Your third is your final, your most serious stage, okay, known as AIDS. When they give meds to a patient, there is no cure for HIV. Well, there's no cure that we know of right now for HIV. So meds delay the progression of it. Okay, we want to delay the progression to getting to AIDS. Okay, when they're in full-blown AIDS, at that point, they can go very rapidly. All right, they get very cachectic. These patients. They can get altered mental status, electrolytes. Pretty much the whole body is shutting down at once. This is just how the infection process works. Okay, see the effects of the HIV infection. So when HIV enters that CD4 T cell count, the host cell stops being an active immune system cell and becomes a virus factory, okay? Body's taken over by those HIV cells. CD4 and T cell count falls and the viral number will increase. Okay, that's like the patho behind it. When this patient goes into full-blown AIDS, it means that CD4 count went below 200. All right. So if you're looking, let's say you see the CD4 count and it's, let's say, 180 or something like that, it means that usually it's a telltale that they're in full-blown AIDS. Okay. It's classified in different classes. So 0 to 2 is HIV stage 2. And then 3 is where I said that they have that T cell count is less than 200. It can take months to years. Timing depends on how it's acquired. Okay, so these are the questions you're going to ask the patient. Patient comes in. Let's say now we do blood work, and they test positive for HIV. These are the things that you're going to ask them, like, how did this happen? Have you been with anybody? Things like that. Other health problems, their personal factors, intervention. Personal factors, what interventions have they gone through? Frequency of re-exposure, okay? Are they being re-exposed every time, or are they taking precautions? Presence of other STIs, their nutritional status. Do they look cachectic? A lot of times when they come in, they have that sunken in appearance, okay? We want to make sure that they're getting all their electrolytes. They're getting a good calorie intake. And stress, obviously. Sunken in, yeah. Stress. You know that when you're stressed, you get sick, right? Isn't that true? Everybody says it. It's like, I'm stressed. I was having a rough week. And now look at me. I got this head cold. I can't get rid of it. Same thing. There's 1.8 million people living that have new diagnoses of HIV annually. People living with HIV. Most cases of HIV in the third stage in North America occur amongst males with males or adults of either gender who have used injection drugs. Health promotion and maintenance for these people. So HIV is usually transmitted via sexual contact, parentally, or perinatally. It's not transmitted, and this is where your education comes in, okay? You have to educate people because a lot of people, like younger generation, are educated in this, believe it or not. But then you have the people that are older that are like, I can't be around that person. I can't breathe their air because I'm going to get it too, So they can't get it through casual contact, sharing household utensils, towels, linens, toilets. And I know a lot of people, this is a myth that they will say they got HIV from getting bit by a mosquito. It doesn't happen. Sexual transmission, abstinence or mutual monogamous sex with a non-infective partner. Your risk is always becoming infected is always there. So you want to really, practice safe sex. Some sexual practices are riskier than others, so having more than one sexual partner. Safer sexual practices, so here's our sex ed class. Latex or polyurethane condom for genital or anal intercourse, a water-based lube with a latex condom, a condom or latex barrier, which is like a dental dam, over the genitals or anus between oral genital or oral anal sexual contact. Prophylaxis. So if this person has a pre-exposure prophylaxis, They will give a drug. It's called Truvada. It's pre-exposure prophylaxis. Okay. Yes. Like PrEP. Like PrEP. There's another one. It's called. So we have Truvada, and there's another one. It's called Descovy. Listen, with Truvada, this is what you got to know about this. It's taken once a day for exposure. If this person is exposed to somebody with HIV, okay, it's got a black box warning. So you want to avoid this drug in patients with hepatitis B. This medication is for an increased risk, like those people have an increased risk of getting HIV. So men with men, injection drug users. Before they give this drug to a person, they do blood and urine tests. You want to tell the patient, this drug does not replace safe sex. Okay, so they still have to practice safe sex. At that point, I wouldn't be touching nobody, but must be taken for 7 days to get in their system. Now, here's the thing. If they miss a dose, it has to be started over. So they could be on day 7 and they forgot, oh my God, I forgot day 7, it's the 7th day. It's okay. It has to be, they need a full 7-day dose. Has to be restarted. Post-exposure prophylaxis. So this is our CART therapy. So this is like if you're the nurse and you have a Sharps injury, the person who's exposed to somebody who has HIV, people who are in sexual assaults that come in, if you're that ED nurse, people come in not all the time, but every so often you got that person, that male or female, that come in and say, I was assaulted, something happened, and we have to do, we have to put them on medication. So usually with this, they're treated for 28 days. Or until their HIV status is known. I talked about this before. Transmission can be parental, perinatal, or healthcare workers. Healthcare workers meaning we get a needle stick, something like that. You don't know what the patient has. Let's say you are that nurse that does get a needle stick. What will happen is if you're in the hospital and the patient, you get a needle stick, they will obviously, the doctor goes to the patient, tells the patient what had happened, and then the patient will consent to give, obviously HIV testing. You go for HIV testing, and then they will let you know. Usually if it's like a sub-Q injection that, let's say you got somebody's insulin needle, the risk of getting HIV is very low. It's like very, very low. History for these patients. You're going to take a history. What's their age, their gender? What do they do for a living? What do they do as leisure activities? Physical assessment, you're going to assess for a cluster of symptoms. So any opportunist infections, any malignancies, endocrine complications, okay? Do they have hypothyroid? Do they have any kind of like Addison's, Cushing's, things like that? Cardiovascular complications. Remember, anything with cardiovascular, any kind of cardio, it could put you, you can get something else with it. So you want to make sure that their cardiovascular condition is being maintained. All right, lab assessment. So they will do a lymphocyte count. They will do the antibody antigen test, and they will do viral load tests. So like I said, if the viral load is below the level of 200, that means that they have AIDS, okay? Their viral load will be very high if it's HIV. Remember that with the patho, when you're thinking about the patho, that virus factory becomes a factory in the body that's constantly producing virus cells, okay? Viral cells. All right, so with that, we have to prevent these patients. We're going to prevent infection. How do you prevent infection with a patient? You're going to tell these patients, wear a mask, wash your hands, avoid large crowds, okay? Avoid kids, all right? Because kids, we said, they always get they always are sick. Enhancing gas exchange. You want these patients to be going on brisk walks, taking deep breaths in, okay? Managing pain. if they do have pain, that they stay out of pain, because when they are in pain, it affects everything else. It affects their nutrition, their gas exchange, everything else. So being adequately dosed on pain medication. Obviously, you start slow and you work your way up. You're not going to give them right away a dilaudid instead of giving them a Tylenol to start to see where they're at. Enhancing nutrition, having maybe a diary of their caloric intake, making sure that they're eating and drinking and they're getting enough vitamins that they need to get in. Managing diarrhea. If they have diarrhea, that we're giving them maybe a Lomodal or a Imodium, something along those lines. Restoring skin integrity. For when we have problems with skin integrity, you want to make sure that you're applying a barrier over that. You're keeping it dry and clean, but you're maybe putting an Aquaphor and A&D over that. And addressing psychosocial distress for the patient. Maybe referring them. Everybody handles things differently. Some people, especially in this case, they may need to talk to somebody. Okay, maybe managing, like sending them to like a therapist or somebody to talk to. Whereas some people are just like, nah, I'm gonna go for a run and I'm gonna. That's how I let my. I don't want to talk to anybody. So we have to, meet the patient and see what they're comfortable with. Care coordination. So home care management, self-care management, we want to make sure that whatever antivirals that they're on, whatever they get put on, that they take it, okay? That they adhere to a regimen, all right? If they're on that, let's say they were pre-exposed, okay, and they have to be on it for 7 days, you want to educate the patient that they have to be on it for 7 days, and if they miss a dose, they have to start all over, all right? You also want to tell them about rest periods. So for every hour that they're, doing something, is every hour that they're relaxing. You don't want them to overexert themselves, okay? Healthcare resources, there's a foundation for them, all right?